Right, everyone, good morning. Can you all hear me? Um, I've not done this live stream before, so you should be able to hear me, but I won't be able to hear you. But you'll feel free to text either through WhatsApp or on the YouTube channel. There's a bit of a delay. I tested this out the other day, and there's about 5 or 10 second delay. So if I don't answer your question straight away, it's because I haven't seen it yet. So I think we've got 5 or 6 people here, maybe a bit more. Awesome. I might give it just a couple of minutes and just see if anyone else is joining us. There we are. Right, let's get started. I think if anyone else is joining, they can join in. So this session's on renal physiology and buffers. It's a huge topic to go through. So what I've tried to do is reduce it down to just some of the more complicated principles. So there's bits of the curriculum that I just not even tried to cover. And I've divided it into two sections mainly. The first section being on renal physiology, and then the second one on a little bit about the sort of anaesthetic implications and how you would anaesthetize someone with chronic renal failure or acute renal failure, as well as some physiology around buffers. So just the next slide. I think what you should probably take home from this session is what else do you need to read. So there's, I think the majority of stuff here, you'll just have to spend time with the textbook, and you will have covered it before, probably at med school or if you've done any other exams. But I found I presented this last year and I came back to it this time and realised I'd forgotten like probably 80% of it. So it is something you don't really use on a day-to-day basis for the most part. So it is something that you can forget fairly quickly. So this is a slide from the FRCA syllabus. When you start looking at renal physiology, there's a big emphasis on fluids and osmolarity. There's an element of drug metabolism and elimination, pharmacokinetics, and I think that's a separate talk in itself. And then drugs that act on the renal system, such as diuretics. There's a little bit about anatomy, ions, regulation of acid base, and then pathophysiology of acute renal failure. So it's a very quick overview on fluids. You must have seen variations of this diagram before. So the majority of fluid is intracellular. This textbook says 28 litres, and then you've got about a third extracellular, 14 litres. There's movement in the direction that your arrows are pointing to. The take home from this would be to think about what goes in an average day, just from a fluid point of view, and how that fluid escapes. So you see, you drink fluid, and there's fluid within food. Regardless of how dry the food might be, there'll be some water content, and then the breakdown of that food will produce water as a sort of byproduct. In terms of loss of water, there's the sort of regular loss that you get, which doesn't really change much. So things like insensible losses through the skin, loss through feces, but then you've got variable loss within sweat and within urine. So you'll normally get sweat is massively variable. You can anywhere from 100 ml a day to litres, to, a couple of litres a day of loss, and one would have to replace that. And urine is the other thing that can really go right the way down or up depending on fluid status. This next slide is quite I find quite useful to think about. So when we do a plasma blood test, we're looking at what's in the extracellular compartment. So this will be quite familiar to all of you. Your sort of sodium being at around the 140 mark, potassium around the 4 to 5 mark, a small amount of calcium and magnesium, a lot of chloride and bicarb. But then you've got this sort of hidden bit that we don't really see. So, we look at potassium of 2 or a potassium of 3 and, start thinking that's a low potassium, but actually the total body potassium will be even significantly lower, because if you've lost such an amount of extracellular potassium, your total deficit will drop massively. And things like potassium and magnesium is where it's most sort of apparent. So the first principle that I'd like to talk about is osmolarity and osmolality. So starting off with osmosis. So just seeing a few more people just join. Welcome. So osmosis is the process whereby water crosses a semi-permeable membrane. Just if anyone wants to ask a question, just write something down, and if and when I say it, I'll come back to it. So if you imagine a cell membrane is pretty much impermeable to most things, apart from water, and unless it's got channels. So in its sort of normal state, water can pass across, but ions and proteins, etc., can't. So water moves from a dilute solvent to a more concentrated area. So when we start talking about osmosis, we need to somehow quantify a term that defines concentration, which then gives us an idea what direction the water is moving in, how quickly, and that sort of thing. So we talk about osmoles. An osmole is a mole of solute particles. So a 1 mole is essentially a number of particles. So it's a massive number. It's 6 with 23 zeros at the end of it. So a mole of glucose will have that number of particles. A mole of sodium chloride will have that number of particles. And if you go back to A-level chemistry, we would often talk about solutions in a 0.1 moles concentration or 1 molar concentration. When it comes down to physiology, 1 mole is a massive concentration, and when we talk about ionic concentrations, the milliosmole is a more reasonable number to be working with. So that's what's used. Giving you an example of osmolality. 0.9% sodium chloride has 9 grams of sodium chloride within 1 litre. So each 1 gram dissolved in a litre would give you 17.1 millimoles per litre. So when you have 9 grams dissolved, it gives you 154 millimoles per litre. So that's sodium chloride. Now we know that the osmolality of normal saline or 0.9% sodium chloride is 308 or 300 and something. And the reason for that is when you have sodium chloride as a single molecule and you put it in, you put whatever amount of it in, it will fully dissociate within a fluid and it becomes 2 molecules or 2 ions. You get sodium on its own and you have chloride on its own, and when they separate, they are both independently osmotically active. So you have 154 millimoles of sodium and 154 millimoles of chloride. You just add the two together, and that gives you it becomes more osmotically active than you would think as a single molecule. Whereas glucose doesn't dissociate, So whatever amount of glucose you put in, that's how osmotically active that particular solution is going to be. And I think there are some solutions that will divide into three molecules, or some substrates that divide into three molecules, and therefore you would multiply the number by 3. In general, osmolality and osmolarity, so with an L and an R, are essentially the same thing when you talk about physiological levels. The difference is let me get this right. So osmolality uses milliosmoles per kilogram, so it's per unit weight, whereas osmolarity uses per litre, so per unit volume. So at large scales there'll be a difference because of the weight accounting for, because a litre of water and a litre of it does not necessarily weigh exactly a kilogram once you've got things dissolved in it, because it's not pure water. But it doesn't really matter from a physiological point of view. From an exam point of view, I think you need to know that the one with the 2 L's is to do with weight, and the one with 1 L is volume. There is some clinical application for osmolality. So there's a equation for calculated osmolality. So you look at the patient's bloods and you do 2 times the sodium concentration plus the glucose concentration plus urea concentration, and that gives you calculated osmolality. That's useful for looking at hyperosmolar states in the context of one of these components being high. So if you've got very high glucose, then you know that osmolality is high. If you've got renal failure with a very high urea, or all three of them are high, you've got very high plasma osmolality. The measured osmolality is, you take a sample, you send it to the lab, they used a particular test that directly measures the osmolality. It doesn't look at the ions, it looks at something called the freezing point, and can give you an exact number. Now these two numbers will be different because our calculator is only looking at these 3 things, whereas the measured will look at everything. So in some situations that's useful because it gives you an idea of whether there's an osmolar gap. That tells us that there are osmotically active substances aside from sodium, glucose and urea. Now those osmotically active substances are going to be either sugars, proteins, or usually alcohol. One example would be if you're giving mannitol to someone for head injury or raised intracranial pressure. We know mannitol it's a sugar, it's massively osmotically active. You give that intravenously. If you were to do a blood test at that point, your calculated osmolality won't change very much. I mean, it might dilute sodium down a little bit, and just because you've given a bit of volume, but essentially that number at the top will be the same. But your measured osmolality would be quite high because you've got mannitol in that solution. Over time, things will correct because you'll get diuresis and that mannitol will be excreted. But if you imagine the instant at which you inject, you'll have a high osmolality. You often will also check urine osmolality, and that, from a pathophysiological point of view, will give you an idea of why you've got electrolyte disturbances in the first place. I'm not going to go into that, but that's another application. So you're talking about functions of the renal system. Broadly speaking, it gets rid of waste products, maintains water and electrolyte balance, tries to maintain osmolality, has a role in blood pressure management, acid-base management, and effects on red blood cell production, etc. Now, I'm just going to move on to each one of these in turn, and there's, like I said, you can read a whole textbook on renal physiology. So I'm just going to try and focus on things that I personally found quite difficult to picture and understand, and see whether I can explain them in relatively sort of simple terms and in a way where you can remember it. So first of all, looking at GFR. So GFR is sounds like glomerular filtration rate, and it's essentially it's described in the units of milliliters per minute. Now, what does that mean? It means the amount or the volume of plasma that's completely cleared of a substance. So how much plasma per unit time is cleared of a substance as it crosses here. The ideal substance would be one that is as you've got blood flow coming through your afferent arteriole into the glomerular capillaries, is pushed through, but then after that point doesn't get reabsorbed, doesn't get, sorry, excuse me, 1 second. There we go. So lots of text messages and phone calls. So it's a substance that it's filtered freely and then isn't reabsorbed or sent across. And once you find that substance, you can figure out how much you've given into the circulation, how much of it comes out into the urine over a period of time. And once you've got that, you can figure out the fraction that's been filtered across here, and it gives you an idea of how much plasma has come across. Now, we normally use creatinine. Creatinine really only undergoes one. It will go into the renal tubules, and then it's not absorbed, and it's not secreted by these capillaries. In a lab, you would use something called inulin. Now, the GFR itself is determined by a number of things. So it's quite easy to visualize on this diagram that this is essentially like a filter, and this is an inflow into this capillary bed. Now, if you increase resistance at the efferent arteriole, you'll increase the hydrostatic pressure in here, and it will push everything into the Bowman's capsule. So vasoconstriction here will increase GFR. Equally, if you put more blood in here and leave this the same, you will increase GFR, because you're putting more in, increases the hydrostatic pressure, and therefore goes across. So vasodilation of the afferent arteriole will also achieve that. And then there's also a component of osmotic pressure. So if you've got low osmotic oncotic pressure in here, you would think that more will go through, and if you've got a higher concentration up here, then it will hold on to the fluid better. And the control of this is through hormonal and sympathetic control. Just the next slide. This divides up into, so most substances will do one of these things. So we've talked about this particular scenario where it will get filtered and then get excreted, and creatinine is one of them, and that's a substance found as a waste product, and inulin is a non-physiological substance that you inject intravenously. You know how much you've injected, and then you know how much you've measured in the urine over a period of time, and using those two numbers in quite a simple formula, you get an idea of what the GFR is. That's one example. Lot of substances will come into either B or C. B is something that's filtered across. Some of it is reabsorbed, and some of it goes into the urine. So that's things like sodium and potassium, and most other ions. And that's where the kidney does its job, its mechanism of, we need to get rid of any excess, but also at the same time hold on to what we need. And then there's this particular situation where it's filtered across, probably not freely, but also probably not freely, but some of it is filtered across. But it's important to grab all of it back in again. and the substances that will behave like this are things like glucose and amino acids. So they are filtered across, but they are needed. This situation, substance D, so some of it is filtered across, not all, but then as it comes round, even more is secreted in. So some drugs will behave in that way, but something sort of not experimental or something exogenous that does behave in this way is a substance called PAH, and this will allow you to measure the total renal blood flow. So whereas a substance A will allow you to measure clearance, substance D, something that's filtered and secreted, so will allow you to measure the renal blood flow to the nephrons by using the very similar equation that you would use to measure clearance. So that's something called PAH, or p-aminohippuric acid. Next, just moving on to autoregulation. This is a very familiar graph that you see with most organ systems. It's important in the kidney because you want to actually maintain GFR within your physiological blood pressure range. As the blood pressure drops, the GFR will drop because if you think back to that diagram, if your driving pressure is dropping, there's only a certain amount of time before the hydrostatic pressure is so low that the filtration is affected, and same on the higher side. Now, if this was a linear line and there was no autoregulation, what would happen? So the problem, if GFR was to rise and fall with your systolic blood pressure or mean pressure, is that the excretion of your solids and your water will swing so much and so often. So the little changes can be made by the kidneys themselves in terms of holding on to ions or getting rid of water, etc. If the GFR is swinging wildly up and down, it means that you have the potential of losing huge amounts of potassium or glucose or whatever, and fluid. So with the normal GFR, if you think about it from instead of a milliliter per minute, so volume per minute, if you think about your GFR in terms of volume per day, about 180 litres is filtered across. Now, urine production is only about a litre and a half a day. So of that 180 litres, 178 has to be reabsorbed back. Now you can think about that in terms of all the ions. So with 180 litres of water, there's huge amounts of sodium that's put in. Now all that sodium has to be reabsorbed back, and so on. So if the GFR was to increase by 25%, so if this was linear and as you get to a blood pressure of 150 and 60 and your GFR was to come up to here, you'd have a huge increase in water excretion. So this next diagram, let me come to it, looks at renal blood flow and how it suffers with dropping of mean arterial pressure. So there's a degree of autoregulation in this range. So if you look at the bottom graph, which looks at mean arterial pressure rising in a sort of fairly linear fashion, and you look at the renal blood flow, which is a blue line, and you've got the GFR, which is essentially the graph we looked at before. These two things, so your blood flow and your GFR, are quite closely linked, and as you have a low driving pressure, things just fall off a cliff edge. We've talked about increasing and decreasing GFR. I won't do that again, but there's a number of things that affect afferent arterial dilatation. So these are things that will increase GFR because it allows more blood to be going into the capillary bed, and things that constrict the efferent arteriole. Again, these will increase the hydrostatic pressure. And then there's another box of things that will do the opposite, and you're sort of probably expected to memorize most of it. And that's another copy of a previous slide. So thinking of, in just general terms, how is water going to be recovered from the kidney? So once you've got 178 or 180 litres of water going into the nephrons, how are we going to get all that back? And the kidney has a number of ways that it does it, and it's quite a hard thing about any one of them on its own. They all sort of link in together, and that's why it's quite important that you spend some time looking through this. I've personally found that YouTube videos are quite good at animating what's actually happening with sodium, with water, with all the other ions at the various different stages. What I want to focus on is first of all the loop of Henle. So we'll start there, and then we'll talk a little bit about the convoluted tubules and collecting ducts. So the loop of Henle comes in three different parts. Just hold on one second, I'm getting loads of messages. I'll just have a quick look at what this is. Give me one moment. Sorry, apologies guys, that was just an important phone call. So the loop of Henle is divided into three areas. This picture is slightly misleading because you've got the thin descending limb, the thin ascending limb, and you've got the thick ascending limb. It's slightly confusing because it looks like the thick ascending limb is sort of miles away all the way up. And depending on which book you read, it either takes up the big proportion of this or a little proportion, as you see in this diagram. Now most of the heavy lifting is done by the thick ascending limb, and that's how you remember that most of the metabolically active cells are in the thick ascending limb. So that does all the movement and pumping, and the thin bits are just there as sort of allow passive things to happen. So they either block things from happening or just allow things to happen. So that's the first sort of important principle. If you have that as your starting point, then you can you can at least then try and figure out what is going on. So the properties of each bit. So the thin descending limb is highly permeable to water and not really that permeable to solutes. So most of the water that is absorbed within the loop, reabsorbed within the loop of Henle happens here. So it just allows water to cross in. So this would anything in the tubules is going to end up in urine. So if you've got lots of water in there, you'll have very dilute urine. So what this allows the kidney to do is pull water back into circulation, so into the medulla and then out again into the bloodstream. So we've got that little diagram there. It's optimized for this sort of thing, thin epithelium, allowing water to come across. The thick ascending loop of Henle, or let's start with the thin ascending loop of Henle. This allows, to some extent, sodium to come across. Is fairly impermeable to water, but allows some of the sodium ions to cut across. The thick ascending limb, if you look at this diagram, tells you why it's thick. It's got loads of mitochondria, very active, and this actively pumps out sodium, chloride, potassium from the tubules into the interstitium. So it's using a sodium potassium ATPase pump to just constantly pump against the concentration gradient, and it can pump by about 200 by a difference of about 200 milliosmoles. So if the osmolality in the interstitium was 400 and the osmolality within the tubules was 400, it'll be able to push out to reduce the osmolality, the gap to about by 200. So you can have 500 in here and 300 in here, and it can push to that sort of level. And I'll talk about that in a minute when we start looking at osmolalities within and outside the loop of Henle. This is a closer look at the thick ascending limb, what the cell looks like. So on the right hand side here, this is a tubular lumen. This is the bit that will end up in urine, and on the left here is what is eventually, which will eventually end up into the interstitium and eventually into the circulation. So this sodium potassium ATPase pump is where things start. So this will pump sodium into the interstitium. It will create a relatively negative potential within the cell, and also create a sort of low sodium concentration within the cell relative to the tubule. Because you've established those conditions using the pump, sodium will come in through these two transporters. So these are called transporters because they're not active, they're not using energy. The energy is all being used by the sodium potassium ATPase pump, and these then just allow sodium to be pulled in. As sodium pulls in and comes in against along its concentration gradient, because there's lots of sodium in here, not a lot within the cell, and also along the electrical gradient, it will pull in chloride and potassium. So this pump, is the sodium chloride potassium co-transporter, is the one that loop diuretics work on, furosemide and bumetanide. So if you block this pump, you'll keep the sodium and chloride and potassium within the tubules, which will eventually go on to urine, and essentially will hold on to water as well. This co-transporter or exchanger also works without energy, so it works indirectly. Sodium comes in and hydrogen ions go out. You will also have some diffusion in between cells of things like potassium, magnesium, calcium. But this is the important bit. This is the metabolically active pump, quite easy to remember. And then this is what allows the other two pumps to do their work. What happens to osmolality within the loop of Henle? So you might remember, one of the easiest things to remember is that the medulla is very, very concentrated. So as you get deeper into the medulla, the osmolality is high. So the bottom of the loop of Henle, osmolality is sort of 1200 to 1400, and it's lower up at the top near the cortex. So you can see in this diagram, as I was saying earlier, the thick ascending limb is predominantly within the medulla, and that wasn't quite clear from the previous one. The major reason, again, it goes back to the pumps up in the thick ascending loop of Henle. So the best way to see this is actually look at a YouTube video, and I've put a link there which I found was quite useful. But we can work through it. So if you ignore, let me get a marker. So if you ignore all the other pictures, let's just start with this picture. So useful to think of a brand new nephron that's just starting to work, and then see how it goes about doing its job. So you filter plasma. Plasma has osmolality of 300, or 300 to make it easier, it's a bit less. That enters the loop of Henle. So as things go down the descending limb, it's permeable to water, it's impermeable to solutes. Nothing happens because the osmolality on the outside is exactly the same. It's 300. So you can see that here. As it goes round though, and you come up to the thick ascending limb, you've got this pump pushing sodium out into the interstitium. Now, because you've started with 300 in here, it can create a concentration gradient of about 200. So what you see is 400 in the interstitium and leaving about 200. So the urine is getting a bit diluter. If we now go back to the descending limb, you've got urine coming down, or you've got tubular contents coming down. because the concentration was 300 in here and 400 in the interstitium, water will start to leave until you get equilibrium. So water leaves the descending limb until you've got 400 and 400. And what then enters into the ascending limb is 400. So the concentration of what's entering the ascending limb goes up. But the sodium potassium ATPase pump starts doing its work again and starts pumping out. So you get a drop from 400 to 300, and as it gets higher and higher, you get more dilute urine, which leads to a lower osmolality within and even a lower osmolality out, and that explains why you have a gradual increase in concentration as you go down the medulla, and why it's not constantly the same. And if you keep repeating these cycles, so more water is leaving, making this more concentrated, making the ascending contents concentrated. It gets to a point where you're able to achieve a osmolality of about 1200 at the deepest part of the medulla. So this is known as the countercurrent multiplier system, and it's, like I said, it's explained quite well in a video format rather than a textbook format. This diagram adds in the collecting duct just to give a fuller picture. So the collecting duct is something that you can variably open and close water channels in, and because it's going down through the medulla, if you open the water channels, make it permeable to water, you can get very concentrated urine, and if you wanted to make it impermeable to water, that's done by not releasing ADH. One can get quite dilute urine. This next diagram is of the vasorector. I haven't superimposed it on a loop of Henle, but it follows the loop of Henle. You've got the same sort of entrance and then outflow, and the shape is important because what it allows the nephron to do is get rid of the extra water, or reabsorb the extra water and extra solutes that are not needed to keep that concentration gradient, but without washing away that concentration gradient. So as it descends into the medulla, water will start to leave because it's a very sort of thin capillary membrane. Water will leave, solute will enter, but that's not going to get washed away, because as it then starts rising back up again, it gives the solute back into the medulla, reabsorbs the water back in on this side. So what leaves is what needs to leave. It's what needs to be reabsorbed without destroying the hard work of the sodium potassium ATPase pump and the nephron. If this was to dive into the medulla and then just leave at the bottom here, you'd be losing a huge amount of solutes from that medulla. All this would be reabsorbed, which isn't needed. So this is a part of the countercurrent mechanism, or a part of allowing it to preserve. Won't talk too much about the mechanisms of tubular absorption. It's sort of more of the same. You've got the same sort of sodium potassium ATPase pump, which is keeping that electrochemical gradient, and then various different types of channels will allow various ions to be reabsorbed and not reabsorbed, and that's something to go and look up and read about, and try not to get confused about it, because the more ions and channels that you look at, they all start to sort of blur into one. But one diagram that I did want to just talk about is this one, and I found this to be quite useful. So along the bottom, you've got your progress through the nephron. So the proximus tubule, loop of Henle, distal tubule, and collecting tubule, and on the side it's the concentration of the tubular fluid. So as it goes to the proximal convoluted tubule, although a lot of reabsorption is occurring of various things, the concentration of those will either go up, down, or remain the same. We talked earlier about glucose and proteins, amino acids. being completely reabsorbed very early on. So their concentration within the tubular fluid will drop quite rapidly. If someone was very, very hyperglycemic, it wouldn't drop quite so rapidly, and actually it will continue, and you'll end up seeing some glucose or some proteins within urine, as you see in different pathological states. Things that you actually do want to get rid of, so things like creatinine and urea, their concentration gradually just rises as it goes through. If we routinely did biochemistry on urine on patients, you'll find that the concentrations do vary quite widely depending on the physiological state. So if you gave someone a huge amount of sodium, the kidneys will work to try and get rid of that sodium. So the sodium concentration may not be 1, it might be higher or lower if they were in a sort of stress-induced state. But this gives you a rough idea of what things look like, how concentrations change over time, or sort of progress. I've just got a couple of practice questions here, and then the reason I've put them in is this is what the primary MCQ true-false questions look like. They so you'll find that some of these things we have looked at, and some of these are just random questions about similar principles from other areas. I'll give you about a minute or so just to look at them, and I'll give you the answers. Right, so the answers for this question: sodium, there's the following examples of active transport sodium exclusion from cells. That's true because of the because we're looking at the sodium potassium ATPase form. That's what that question is referring to. Water reabsorption from the proximal convoluted tubule. So that's not active transport because the water just follows sodium. It freely just diffuses across because of osmosis, because of concentration gradient already achieved. So that's false. And then it's true, and false again. So you can see, like the glucose question on the gut is something that you wouldn't normally read about in your renal physiology, but it just pulls those similar questions together. I've just got a couple of animations on particular molecules. So we've talked about glucose and how all of it is reabsorbed. These are the sort of graphs you might be expected to draw or label in a sort of viva situation. And it's much easier to do when you actually understand what's happening. So in this animation, the plasma glucose concentration is at the bottom. So this is the American unit, and I do have a graph later which is not as good, but has it in millimoles per litre rather than milligrams per deciliter. But this 100 mark, or 200 mark, sorry, is about 11. So this here is about a blood glucose of about 11. You've got 3 lines coming up. So it starts about here. The blue line is reabsorption, or the amount that's reabsorbed. The red line is the filtered amount. So let's just watch that. So as you see, as the plasma glucose concentration goes up, all of it is being reabsorbed until you get to a point at about 11 millimoles per litre that the amount filtered, the red line, it just keeps getting more and more filtered, but the amount being reabsorbed starts to plateau off. And as less is being reabsorbed, you start finding more and more of that glucose entering urine, up until the point where you get a complete plateau of reabsorption. So that's all the channels that would be reabsorbing glucose are working at full pace, and they can't reabsorb anymore. So as the plasma glucose concentration goes up higher than that, the excretion just becomes linear. This is the next picture is one from a UK textbook, and it gives you the numbers in millimoles per litre. It also labels this term here as Tmax. which is the maximum capacity of the channels to be working at. So the glucose at a cellular level works in a very similar way to how the pump in the ascending loop of Henle works. So there's a concentration gradient, electrochemical gradient achieved by sodium being pushed out of the cell. That then allows sodium to come in and pull glucose in with it. And once glucose is in the cell, there's a concentration gradient that allows glucose to be pulled back into the interstitium and into the blood. The same with amino acids, and you've got pathological situations where glucose is filtered across and found in urine, so things like hyperglycemia, and when it comes to amino acids, if the filtered load is very high, so you won't often find situations where there's too much amino acids, but what you'll find is that it's just getting filtered across the glomerulus because of a leaky capillary membrane, and because there's now so much in the proximal convoluted tubule, only a certain amount of it can be reabsorbed, and you end up having proteinuria. So what we find in nephrotic syndrome, essentially. So sodium's an interesting one because although loads of sodium is moving back out from the nephron, the actual concentration within the tubules has quite large swings, and that's because depending on whether water is leaving with it or without it, the concentration changes. So the proximal convoluted tubule, about 60% of the sodium is reabsorbed at this point, but the concentration remains the same because the same amount of water comes with it. In the descending limb, we talk about water being reabsorbed, and the sodium being stuck, so the concentration goes up. And then as you go up the ascending limb, sodium is now being pumped out intentionally, and the concentration within the tubules is dropping. And then in the distal convoluted tubule and the collecting ducts, anything can happen. This is where the fine-tuning happens. If sodium needs to be excreted, it is done here. And that's done by either concentrating or diluting the urine, which is done by ADH. So ADH being present, antidiuretic hormone, it will insert aquaporins into the collecting duct, which will allow water to freely just leave, go into the medullary interstitium and be reabsorbed. Leaves the urine very concentrated, means that you've got a high concentration of sodium within that urine. Doesn't necessarily mean that you're losing more sodium, because it can be a low volume of high concentration, whereas if there was no ADH, you then lose a lot more urine. It could be that your total amount of sodium being lost in this situation could be higher. Potassium slightly different. Let's get this one to work. So essentially the concentration will stay the same because it sort of moves with water, and so it starts off at a low concentration, so swings in it are not seen as much. It's in the distal convoluted tubule, it is secreted along its sort of electrochemical gradient. The reason I've added potassium in here is because the amount of potassium that is lost in the kidneys it does depend on the urine flow. So if there was a high urine flow, as is the case with diuretics, or in someone having a diuresis for whatever reasons, and intensive care as their AKI is resolving, they will lose potassium. So in general terms, a high urine flow will mean a larger amount of potassium being excreted, although the concentration might be lower. As you can see here, the amount of potassium leaving will be higher. This last one is a little sort of thought experiment, and And what it's saying is, over a period of time, what happens when someone drinks a litre of water? What's happening with osmolarity? So that's the plasma osmolarity, which is the black line that you'll see in the top diagram, and urine osmolarity. So someone drinks a litre of water. Water has no osmotically active molecules. It is just water. What's going to happen? What happens to the urine flow rate, and then what happens to the urine solute excretion, which is not as interesting, but just the top two are quite interesting, just to think about what's going to happen and see. Let's get this working. There we are. You can see someone drinks water at this point here. The plasma osmolality, which is red line, is quite tightly controlled, drops a little bit, but your change in urine flow rate goes up because you've got this excessive fluid, and the concentration, or the osmolarity drops. Although the concentration drops, the amount of solutes having to leave does go up slightly. So with the higher flow rate, you are going to lose more solutes, a tiny amount more, but the concentration of that urine is going to be low, and over the course of 3 or 4 hours, things will correct themselves. Get rid of this pen because I can't move forward otherwise. There we are. This is a diagram that looks at all the different molecules, and just I find it interesting from the sort of numbers that you can see. So 180 grams a day of glucose goes into the proximal convoluted tubule. All of it is reabsorbed, so 100% of it is reabsorbed. Sodium, which plays a massive part, most of it, or 99.4% of it, is reabsorbed. That tiny bit is what you end up losing in urine, but it plays a huge part in allowing all the other stuff to happen. And then the actual waste products like urea and creatinine are the ones that do go away. A lot of urea is reabsorbed, and it is slightly more complicated when you start thinking about urea. So I've decided to leave that out. But as a waste product, the majority of it goes away, and creatinine, all of it is excreted, and that's why it's a good determinant of GFR. If you're not seeing any creatinine in urine, or you've got a very high creatinine in blood, that means that your GFR is obviously lower. An interesting concept is obligatory urine volume. So what's a minimum amount of urine that can be produced? And there needs to be some amount of urine being produced, because there are going to be things like the creatinine and urea that need to be excreted. Now, the kidneys have a maximal concentrating ability, and this is different between different mammals. So for humans, a 70 kilogram male needs to excrete around 600 milliosmoles of solute per day. Now, the maximum concentrating ability is 1200 milliosmoles per litre. So if that male that 70 kilogram person had to get rid of 600 milliosmoles, and the maximum concentrating ability is 1200 milliosmoles per litre, that means that half a litre of water needs to leave without 600 milliosmoles. There's no way you're getting rid of that solute without also losing half a litre of water. So that's a minimum amount of urine that needs to be produced. Now, from that you can follow why can't we drink salt water? So salt water has sodium within it, and the osmolality of salt water, or seawater, is 1200 milliosmoles per litre. So quite a lot more than your sort of normal saline. So you would think, because the maximum concentrating ability of urine is 1200 milliosmoles per litre, if you were to drink a litre of seawater, you would lose a litre of your water, and everything would at least be in balance. But actually it dehydrates you, because when you drink a litre of seawater, you've got the 1200 milliosmoles of solute that is within that seawater that needs to go, but you still have to get rid of the 600 that you were getting rid of already. Therefore, for each litre of seawater that you drink, about a litre and a half of urine also needs to go as well. So that's why it's a bad idea. These are the hormones that you need to think about when talking about control of GFR, of excretion, of the kidneys as a whole. It's all quite dry and much easier to sort of read it from a book, so I'm just going to skip over that slide. I've got a few questions. Again, same reason as I put the previous ones in. They give you an idea of how the exam tries to tie things together. So I'll give you a minute just to have a look at that. I'll give you the answers. So the answer for all of these is true. So in hypovolemia, the increase in these are the sort of things that will happen. So all of them are true. The next question looks at surgical stress response. Give me another 30 seconds just to have a look and get some answers down on paper. So the answer for this one, so autoregulatory mechanisms used in hypovolemia include, oh right, no sorry, I haven't actually moved on, apologies. So this is the next question. So normal response to surgery includes a decrease in urine volume, decrease in excretion of sodium, decrease in cortisol level, increase in excretion of nitrogen, increase in excretion of potassium. So the answer here is true, true, false, true, true. And then there's just one last one on renin activity. I'll give you a minute with that. So the answer to this one is true, true, false, false, and then true. The next bit of the talk goes on to acid-base balance. So what I suggest is let's have a 10-minute break, get yourself a drink, and then I'll start back at about 10 past 10. So I've just seen Neha say you didn't get a question. Was that, which one do you want me to go back to? Or if there's any other questions, just type them up, write them in, or write them on the WhatsApp group, and I'll see if I can answer them. Okay, if there's no questions, we'll get back at about 10 past 10. Right, everyone. Thank you to whoever that was who's taken the register. Jamie, isn't it? Yeah, thank you. I'll just start the next bit. I think the second bit of the talk is shorter than the first bit and slightly, I think, easier to understand. The So focus is going to be on buffers and anesthesia for the person with renal failure. Yeah, can you hear me, Neha? Hopefully, yes. It's quite weird with the lag. So, so quite important from a homeostasis point of view to maintain a pH in quite a strict range. So we know pH is essentially the minus log of the hydrogen ion concentration. The way the physiologically the body reacts to changes in pH can be divided into immediate, so in essence straight away, things over a period of minutes, and then longer term changes that can be made. So the immediate change the immediate response to a change in pH is achieved by buffers. So if there's a sudden increase in hydrogen ion production, the buffering system will allow maintenance of the pH within a range. And over the next minutes, respiratory rate will go up to excrete increased carbon dioxide and drop the acid load. And if this is a persistent acidosis over a period of hours and days, the kidneys will kick in and start to retain bicarb and start to excrete hydrogen ions. So the bicarbonate buffer system is the most powerful physiological buffer system that we have. And I got asked this question in the Viva, and I'd say probably 80% of the question was on the bicarbonate buffer system and how it works and what sort of the equations around it, and looking at the graph for it. So I'll spend a bit of time talking about that. Sorry. So it has two components. Apologies, this sort of copied pasted these equations. They must look really bad on the stream. So very simple equations that you need to look at. So carbon dioxide and water can combine together to form carbonic acid. This is a very slow reaction unless there's carbonic anhydrase present. So essentially, you get something that is present as in solution that can be converted into a gas and water. So this reaction can't happen everywhere. It can only happen where you've got carbonic anhydrase, and this enzyme is predominantly found in alveoli and in renal tubules. So everywhere else you'll have this substance, swimming around, and then when it gets to the lungs, it can get converted to carbon dioxide and excreted. I guess the kidneys, it can get converted to hydrogen ions and bicarb, and one of them can get excreted and one can get reabsorbed back. So this second equation where carbonic acid dissociates in solution, it's a weak acid. So in any given solution, some of it will remain in the unionized state, and then some of it will be in the dissociated ionized state. And physiologically, majority of it will be to the left, less of it will be to the right. This is the first component of the bicarb buffer system. The second component looks at the bicarb salt, which is predominantly as sodium bicarb. This is different in that when you put this in solution, the majority of it will go to the right hand side, so you'll get a lot of it ionized and not very much of it in the unionized state, and it dissociates into sodium and bicarb. When you put the equations together, you get this sort of dynamic equilibrium, and depending on whether you're in the lungs or whether you're in the kidneys, the equation will favour one or the other. So this is the first bit of the equation, and then this is the second bit of the equation, where bicarb is sort of present from the sodium bicarb that we find physiologically. Now, if you did a little sort of thought experiment and you put acid into this system, what would happen? So if you spill a huge amount of hydrogen ions into this system, and I've said that the immediate pH control is by the buffers, by the bicarb buffer predominantly. How does it happen, and what happens to the equation? So what will happen as the concentration here increases, the equation starts to shift to the left and converts into carbonic acid, and your concentration of this goes up. The pH is therefore maintained to some extent. There might be a change in pH, but it's not going to be as great a change as if there was no buffer. So your hydrogen ion concentration, instead of shooting up, in the absence of the buffer, it would just shoot up to whatever hydrogen ions you've put in. But because there's a buffer there, most of it will get converted to this state, because this particular equation likes to go to the left. And there will be maybe a slight rise in your hydrogen ion concentration, but the pH will be relatively steady. As this carbonic acid makes its way to the lungs, it will go to the left, carbon dioxide will go out, and it makes more room to produce more carbonic acid. Conversely, in the kidneys, the hydrogen ions can be excreted directly, but we know that takes hours rather than instantly. So the instant bit of this equation happens here, moving directly to the left, the buffering as it were, and then the slightly longer bit is getting rid of the CO2, so there's happening here, hyperventilation, CO2 goes, and that takes a bit more time. That's a compensatory mechanism, and then the kidney is a longer term mechanism. And I think this equation just describes that. So converting a strong acid, lots of hydrogen ions into a weak acid, and then just getting rid of it from a respiratory point of view. I'd like to spend a bit of time on this next diagram, and I think it's really important you get your head around it, because there's a slight paradox with it, which every time you come back to, you just have to try and remember why it is the way it is. So let's start off with pKa. So the pKa of a substance is the pH at which half of it is in the ionized state and the other half is in the unionized state. So if you look at this, the bicarb system, that is saying half of it is in the in the ionized state, so you've got 50% of it as a buffer. So a buffer works best at about one pH point above and below its pK, because you've got loads of bicarb, you've got loads of substance that can either absorb hydrogen ions, and you've got loads that will absorb any alkali. So as you change pH, as you add either acid or base, the change in pH is not that great. So the pK of the bicarb buffer system is actually 6.1. So this buffer system actually works really well between a pH of sort of 7.1 and 5.1. And you can see from this curve that you can add quite significant amounts of, say, base, but the pH only changes a little bit. So you can go up by quite a lot, but you go sideways a little bit. And as you go outside of its range, you go up by the same amount, and you're coming out way more. And same with acid. So if you add, or you double the amount of acid, or add a significant amount more acid, the pH only drops a bit. And then if you add the same amount again, it drops all the way down to 4. Now this is the first sort of paradox with it, because physiological pH is not in that range that we just said, of 5.1 and 7.1. It's actually 7.4, and we are on a fairly flat bit of the curve here, in that it looks like you add a little bit of acid and the pH drops quite quickly, and definitely from a base point of view, you add a little bit of base and your pH shoots all the way up. So we have to agree that the bicarb buffer system is the most powerful physiologically. It's what allows instantaneous maintenance of pH. But why does it allow that? Why, from everything we've said, it doesn't seem like it is ideal, because you're working way outside of its range. The curve doesn't look favourable at all in that area. The second reason why it doesn't seem like it'd be a good buffer is because the actual concentrations of bicarb are not that high. If you think of your concentration of sodium and other osmotically active ions, bicarb is actually relatively low. It's about 20-ish. So it's not as if there's a huge amount of it in the plasma. But there is a reason why it's powerful. That's what I'm coming on to. It's because both components of the buffer system are quite closely regulated by the kidneys and by the lungs. So although you haven't got a huge amount of it around and you're not working within that system, within its ideal sort of concentration, as a pH, it works because of the ability to just keep adding more base in. So if there's acid coming in, the kidneys can start to retain bicarb and keep it working. Same as the lungs, they can get rid of that extra acid and keep it working, and that's why it's such a strong system. You need to have an awareness of other buffer systems, so what they are, where they're found, where they sort of work. So the two other main buffer systems are the phosphate buffer system, and this one doesn't really work much in plasmates. It's not really present in plasmates, mainly in the renal tubules, and is involved in allowing hydrogen ions to be excreted. The other buffers within plasma that help maintain pH are general sort of proteins and hemoglobin. They both allow mopping up of hydrogen ions. Carbonic anhydrase is also found in HB and is involved in sort of buffering within that level. So that's essentially buffers. I think that principle, the graph you should be able to draw, um, you should be able to mark out a pKa and just sort of describe in a stepwise manner that as you can increase the concentration of something, the pH doesn't increase much, and then as the curve starts to plateau off, you get massive swings. But despite that, at physiological pH, the bicarb buffer system is powerful because of the ability of the kidneys and the lungs to um, help in maintaining the concentration of the buffer. Uh, so this is another example MCQ I think I found from a book or from a website. So carbonic anhydride is found at high concentration in so plasma, red blood cells, renal tubular cells, gastric parietal cells, and cardiac muscle cells. So no, not in plasma. We've sort of talked about that. It's found in red blood cells. It's found in renal tubular cells. It is found in gastric parietal cells, but for different reasons. It's not found in cardiac muscle cells, and we've said that it's also found in alveoli. Initially, when I did this talk, I was thinking of talking about the clinical implications of renal disease, and actually that's such a massive subject that I'm going to skip over most of it. From an acute kidney injury point of view, make yourself aware of the KDIGO scoring system. But apart from that, I think it's such a big topic to go over, and it's something for perhaps another day. The management anesthesia in patients who've got either CKD or AKI, and you have to think of the two syndromes as very different syndromes. AKI is very different to CKD. It can be quite challenging. So patients can present for either surgery related to their kidney disease. So you might see them on a vascular list coming in for fistulas or CAPD catheters, or renal transplant surgery. All these are people on dialysis who are coming for any other operation, but it's higher risk surgery because they've got other comorbidities that are associated with the CKD. They have the condition that causes CKD in the first place must have been quite severe. So if someone's hypertensive or diabetic and they've got to the stage of a sort of microvascular complications such as end-stage renal failure, you can pretty much guarantee that that effect is happening elsewhere. Fluid balance is quite tricky. Acid base and electrolyte balance can be quite tricky as well. So in the context of AKI, you might come across patients who are developing AKI because, for example, on an emergency list, because they've got some sort of obstructive cause, renal stones, hydronephrosis, and these patients you will need to assess quite closely, make sure they're not on any other nephrotoxic drugs, get an idea of the severity of AKI, what's their fluid balance like, are they producing any urine at all, what's the potassium like, what's the urea doing. If it's very high, you can get uremic symptoms, and then what's the acid-base balance like. Some of these patients can get quite severely acidotic, which affects your perioperative management. So the issues predominantly for us come down to either fluid management, potassium management, and in the longer term within CKD, anemia, the changes in cardiovascular system. Some of these patients can be very hypertensive. Venous access can be difficult because they've either had fistulas everywhere or had so many lines that it just becomes very tricky to get access. We talked about urea and and from a cardiovascular system point of view, I have seen a couple of cases of urinary pericarditis, mainly in the ITU setting, to be honest. And in quite advanced renal failure, things like secondary hyperparathyroidism and calcium changes need to be managed. What my own experience working and doing vascular is that the majority of these patients, when they get to this stage, have such sort of intense renal input that most of these electoral abnormalities will already be looked at, and there'll be a plan in place to optimize them. So for the CKD patients coming in either for acute surgery or just coming in for any routine surgery. Just 1 second, guys. There'll be a plan in place for the acute, for the ones, AKI type patients being admitted. You would follow your general principles of seeing how well they are from an electrolyte acid based point of view, and make your decision based on that. And it might mean that they do need dialysis preoperatively. In terms of optimizing patients, nutrition can be part of your plan. Blood pressure control, correction of anemia depending on what operation they're having, because most of them are anemic, and then plans around dialysis, and that's dialysis before surgery, and then dialysis after surgery, and organising something if it's not already been organised. This next table. Sorry, I've got to go through all the slides. So this next page looks at drugs used in anaesthetic practice that depend significantly on renal elimination. Just to look at muscle relaxants here. So atracurium is probably your drug of choice because it doesn't rely on any sort of it doesn't rely on metabolism to the same extent as rocuronium, but rock isn't metabolized by the kidneys, mainly sort of hepatic metabolism. So there's a whole list of things. If you've done your ITU or module yet, you'll find that we often use the renal drug handbook, and that gives you much more detailed information about each drug. It's quite easily found if you just Google it. There's a PDF around that you can get access to. I think I've again repeated the slide. That doesn't look. So just talking through a typical case, what would you avoid in induction of anaesthesia? So in terms of your routine drugs, you're probably okay with what you normally use. It's just the way in which you use them. So succinylcholine, for example, in a patient with normal potassium, it's fine. Unless they've got a very high potassium, you'll be okay. So there is a potassium release, but it's not any more exaggerated in someone with CKD. So if you've got a patient who's been dialyzed, the potassium's 3 or 4, the potassium release is not going to be any different than someone else with a potassium of 3 or 4. If it's 7, then obviously use something else. I think from experience, most people use atracurium. But I think regardless of which drug you use, this would be one of those cases where using a nerve stimulator, if you've intubated them, would be a good idea in reversing them properly. Blood pressure might be more labile, mainly because majority of these patients have got CKD because of blood pressure issues or diabetes, also that same sort of syndrome. So be gradual when you give your propofol and metronidazole. In terms of maintenance, the drugs that we normally use are fine. The textbooks will tell you that sevoflurane at very low flows can result in nephrotoxic ions, fluoride ions being produced within the circuit. Now, it's all quite theoretical. I think when sevoflurane first came on the market, there was some advice to not use it below flows of about half a litre a minute. So you could go to that. Half a litre is fairly reasonable. It's not it's low, it's not ultra low flow, but you keep your flow slightly higher in someone who's got renal failure. But then the argument is, if they've already got renal failure, then it probably doesn't matter so much. It probably matters more in the ones that haven't got renal failure. I think that's all theoretical. It's also animal models, and there's no actual evidence in humans that sevoflurane causes renal injury. Opioids are probably the drugs that you need to think about most. So their excretion metabolism is affected. If the drug just accumulates over time, they will get more and more drowsy and go into respiratory failure. And you might have come across patients who've been getting codeine on the ward, or have had a bit too much morphine, and it just doesn't really wear off. They can't get rid of it as quickly. Neostigmine hangs around longer in CKD, so its effect just is longer than it normally expects. So you will, once you reverse someone adequately, then they shouldn't be they shouldn't get residual neuromuscular block after that point. Generally speaking, we avoid Hartmann's and plasma light because of the potassium content. Now, there's a lot of controversy and discussion about the fact that the actual amount of potassium in a bag of Hartmann's is tiny compared to the total body stores of potassium. So even in someone who's mildly hyperkalemic, using Hartmann's is probably still better because of the advantage of it being a more balanced solution than giving a lot of saline. Saying that, I personally use saline in the fairly short cases that I do in patients with CKD or AKI. Try not to give too much fluid at all, to be honest. If they've been recently dialyzed and they're fairly euvolemic, then I try and keep things to a minimum. It's very easy to overdo fluids or get them too dry. So they sometimes are a bit dry when they come from dialysis, and then you don't need too much fluid, just get them back to euvolemia. This also goes for pregnant patients in preeclampsia, which is sort of almost an extension of nephrotic syndrome. But they also can get quite it's not as easy, but it has been where they develop renal failure, acute renal failure. I've had obviously a load of fluid to try and crack that, and then the next thing you know, they're in cardiac failure with pulmonary edema, just because they can't get rid of that fluid that's been infused. Just things to think about in monitoring. Try and avoid A-lines. So even in renal transplant surgery, unless it's a really strong indicator, try not to do A-lines, because the radial artery is often used for production of creation of a fistula. The other thing that the surgeons appreciate us not doing is cannulating the big veins in the forearms. So prefer cannulating the hand veins, just because they're used for creating fistulas. CVP lines, they are put in usually in renal transplant patients, but for more minor surgery, probably not necessary. But this group of patients, when you're putting lines into them, and you'll find that when they come up to ITU for whatever reason, and you're trying to put a central line in if they haven't already got one, they can be really tricky. The vessels are small, they're thready, they bend. You can't get in, or if you get in, you can't get the wire in. Or if you've got the wire in, you can't actually get the line in. There's so many difficulties, and I remember one patient probably about a year ago on ITU that they ended up dying just because we couldn't get dialysis access. all possible fistulas had been created and failed. The renal physicians couldn't get any lines in for dialysis, and then we tried, right neck, left neck, right groin, left groin, and failed. I just couldn't get a line in, and had a discussion with the family and said, maybe this is where, where we call it a day. So lack of access, lack of dialysis access, does happen. This is another table, gives you an idea of what you should be doing with doses with different GFRs. Again, if you want to look up a particular drug, the renal handbook is fantastic. It gives you all the different scenarios that the patient might be in on dialysis, on filtration, GFR of whatever range, and then what do you need to do with that drug. So things like morphine, you're going to need to reduce the drug dose. Things like remifentanil that are metabolized by plasmapheresis, you don't have to do anything different. But codeine, fentanyl, they will accumulate. Probably the first dose probably doesn't make that much of a difference, but certainly doses after that, you need to think about how much you're giving, especially considering some of these renal patients can be quite small in size. So I talked about the type of surgery that these patients might come for. Mainly at Heartlands, we do a lot of fistula formation and CAPD, and the renal transplants are mainly done at Coventry and the Children's Hospital. It's actually a relatively straightforward procedure to anaesthetise for. There's usually quite a protocolized document on how to do it, what drugs they need at what time, because it's a fairly consistent operation between patients. And then the post-op management for these patients is also quite protocolized, depending on their fluid loss. You need to calculate how much fluid you put in, etc. But they generally all go to HDU at Coventry at least. So in terms of reading, like I said earlier, YouTube's quite a good resource, particularly for the kidney, because a lot of it is quite dynamic, and seeing that in a video really helps. The level required for the FRCA, I think, is quite a lot, because they can pick any one of these topics and they can spend 5 minutes or the whole of your Viva just talking about the nephron, for example, or you can have a question on diuretics, and that is your drug question, your pharmacology question. So there is a fair amount of material in renal. I personally found this book really good. There's a lot of content to it, but it's just really easy to read. And there's also the Chris Lote book from Birmingham Uni that a lot of people read. I quite like this anesthesia and coexisting disease book. So it's a bigger version of the Oxford Handbook of Anesthesia. So when you come to anaesthetising patients with significant comorbidities, this is a great sort of reference book to look at what things you need to be thinking of. So, for example, in renal failure, so that the tables with the different drug doses came from this book. So, in the context of renal failure, what should you be looking for in your pre-op assessment? How do you manage them for either particular types of surgery or for generic surgery, intraoperative management, and then how you manage them post-operatively? It pretty much any question that you have, you'll be able to find it in the book. And lastly, I think this is a great book for reference if you haven't already got it. That's it for the talk. There's a feedback link in here. You don't bother filling it in because I think Jamie's put another one on the group. But if you click on this, at the top there is a link to the slides if you want them. I've left notes on the bottom of the slides, but they may not be that useful. They're more for myself. But if you want the slides for the pictures, feel free to download them from there. Any questions, just either put them on the WhatsApp group or put them on the chat and I can try and answer them. It might be worth giving Ash some feedback on how you felt this went. Um, I think with things going the way they're going, all teaching probably will just end up being cancelled anyway, because you're needed uh, to just deal with the service demands. But if it was going to go ahead, I think it might be that we follow this sort of mechanism. It's not ideal because there's only a one-way system. I'm talking and I can't really engage in any sort of dialogue with you guys. But yeah, let Ash know how you found it. So if there's any questions. Right, I'll give it another minute or so, just make sure there's nothing there. But thank you everyone for attending. That's really good attendance. I think I can see that there's like 19 people or 18 people on it, which is really good. Yeah. Yeah, and good luck to everyone over the next few weeks and months of working on ITU. Right, in that case, thank you. I'll log off. Have a good day, and see you when I'm back at work.